for a teaching module. So welcome. It's been a raining morning. Can I just quickly have a show of hands, if we may, also for the speaker's sake? How many of you are here as, I am a PI and I would like to know how this is being done? Okay. How many of you I help to run some of these things and I would also like to see how it's being done? Okay. How many of you are here to just listen and find out what you can do in the future? All right. So so for you, it's less formal than you think. So just be comfortable. We will have the speakers speak through 20 minutes roughly. We have 4 speakers. I'm still missing 1 speaker, but she will come. Where's she? Oh, hello. So we have 4 speakers today. They will talk about cohorts, population studies, biobanking, data science, and the one that's most relevant to the local people folks here is the trust platform. So we have Joe, we have Pearl, we have Andrew, and we have Mingshi here. So let's just get started, and then there will not be questions during the sessions, but at the end of it, we'll invite all of them to sit down and have some question and answer session. I will post the questions first, and then we'll have time for some of you to post questions, and then at 12 we'll adjourn for lunch downstairs. Good? Okay. So let's invite our first speaker, Joe McNamara. He's the head of cohort strategy at MRC, and he's going to tell you about cohorts.
Thank you very much, and thank you, Sealing, for the invitation to speak to you. I'm going to be telling you a bit about my perspective as a funder on longitudinal population studies or longitudinal population cohorts, and give you some idea about what the funding environment is in the UK and how we manage these very large applications when they come in as a funder. Now, you may well be asking, why is this of relevance to me? And that's a very good question. I hope I will make it relevant to you, but I think it's very useful for you to see the sorts of questions that funders ask themselves when they embark on funding large-scale population studies. So hopefully it will be of use for you, to you in that way. So that's me. I'm part of the Medical Research Council in the UK since 2018, is part of the UKRI, UK Research and Innovation, which was a body that was launched in, as I say, 2018. And although it's arm's length from government, it does have a government sponsor, which at the time was Department for Business, Innovation, Energy and Innovation and Development, and now is a new department which was brand new on the scene in February, which is Department for Science, Innovation and Technology. So our funding does come from government, but we're arm's length from government, and we have autonomy in terms of the decisions we make. The UKRI is the largest funder of research and innovation in the UK, and the budget there is, as you can see, about 9 billion UK pounds sterling for the years 22-23. It comprises 9 organisations, 7 of which are research councils, one of which is the MRC. We work with right across the board with the other research councils. There's also Innovate UK, which is the innovation body that drives innovation in business in the UK. That's part of UKRI. And Research England, which supports the research environment in universities in the UK. MRC has been around for quite a long time, long before UKRI came into existence. We were set up in 1913 in response to, not as a council, but thank you, not as a research council, but in response to a tuberculosis epidemic in the UK, which was where there were research questions that government were interested in having answered. And from then we went on to become a funder of medical research, and some of the highlights of our funding are on this slide over the 100 years or so that we've been around. Our mission is to encourage and support research to improve human health. That's pretty obvious. We also have a training and capacity building mission. We have to work with industry in the UK and support research that is translated into new treatments, new products that go forward and help improve health. And we also have a responsibility for public dialogue and informing the public about science and scientific issues and talking about medical research. Just to give you a quick overview of how we're structured and how we work, and this is relevant to how we fund our longitudinal population studies later. At the top, obviously, we have a council, which is the governing body of the MRC. Below that is the strategy board, which our chief executive or executive chair sits on, and strategy board and the 5 boards below that, which are molecular and cell, populations and systems, infections and immunity, neurosciences, and applied global health. Those 5 boards all have their own budgets, and they're allocated on an annual basis. So you can see from the names of the boards, those are the main domains that are covered within our remit as the MRC. And the boards are really the engine room of our funding operations within the council. So all the response mode applications that come in are funded largely, most of them are funded largely through the boards. Our units and our institutes, when they come up for review, are funded by the boards, or for the institutes, they go to strategy board because of the larger sums of money that are involved, and some of the bigger investments go to strategy board as well. And then you can see on this diagram, I've tried to show where we've got these cross-cutting themes, which include population health sciences, translational research, training, of course, goes right across all the board domains, as does data science. So that's kind of how that's the structure, and that's the structure that we're working within, and that's the funding structure going forward. So it's important to keep that in mind in terms of what the challenges are for then funding longitudinal cohort studies. So I probably don't need to say to this audience the reasons for why you would want to fund population studies, but I have set out a few of them just to remind you all. We do think they're really important instruments for taking forward research in a particular way, and they can deliver things that other studies, clinical trials, cross-sectional studies, for example, can't necessarily provide. And they have a richness of data that can inform new treatments and inform development of new hypotheses, some of which are set out there, and you can read them. I don't need to go through them. In terms of some of the assets, and I've been very selective, and it's really a personal selection here, which I've picked out in terms of things that we fund or we're very actively involved in. Some of you will be aware of the UK Biobank, a study that was set up in about 2002. It finished recruitment in 2010 after 4 years of recruiting to get to 500,000 participants, volunteers that joined the study. Opened for business, as it were, to the research community in 2012, and has been open ever since. And you can see there recruited individuals in the age group in their 40s into their 60s, and has been following them ever since. The Biobank itself is an open platform, a global platform for research. At the last count I saw, there's something like 30,000 researchers that are registered to use the study from, I think it's almost 90 countries across the world now. So it's a truly kind of open resource, and is used widely, I think. So we're proud to be associated with that, and Biobank does a very good job. And I should point out that we don't fund it on our own. It's also funded by the Wellcome Trust, which is a major UK biomedical research charity. Another new cohort that's been starting up, so we're not just sort of sitting on our laurels. We've been involved in setting up of another study which is going to be 10 times larger than the UK Biobank, called Our Future Health. It's still on its journey of recruitment, so there's still quite a long way to go, but we're hoping to set up a population study of 5 million when our Future Health is up and running. It's different from UK Biobank in a couple of important ways, in that the age range is different for a start. It goes from 18 into late age, so there's no upper age limit. There will be feedback to the participants, so Future Health are thinking about how you feed back information, for example, information derived from genetic risk scores and so on and so forth, which is not a trivial issue, so that's been thought about how that goes back to people. And there will also be consent for recall, so that we can recall the members of the cohort to be involved in studies going forward. And that's different from UK Biobank, where there's no feedback and there's no recall to participate in studies. There's another couple of initiatives I've just flagged up there, which are Population Health Research UK, which is Andrew's team at Health Data Research UK have been closely involved in helping us set this up, which is something where we're trying to galvanize and liberate the rich data and other assets which are associated with our longitudinal studies, which otherwise can be siloed and don't necessarily get shared and worked on and exploited as much as they might do. So PR UK and it's very germane to the discussions we've been having here in Singapore over the last few days, how we exploit data and samples that are associated with our longitudinal studies, and I'll come back to that in a little bit. And I'm also involved in setting up a new cohort, which is under active development at the moment. We've just got the funding, making the case for the funding to go through. This will be a cohort focusing on adolescent health. We're hoping to recruit 100,000 participants in the age range of 8 to 18 and follow them through for 10 years. And so that will be looking at issues relative to adolescent health, issues like mental health and so on and so forth as we go forward. But that's in the very earliest days of setting that up. But you can see it's still quite a vibrant environment for longitudinal and population studies in the UK as we go forward. Now, coming back to where I started this talk, which was about the challenges for funders and how we view longitudinal population studies or longitudinal cohorts. And I just wanted to share with you, they're just off the top of the head, a few remarks and ideas, but just to give you a funder's perspective on getting involved in these sort of research projects. So I think the first thing, and it's going to be self-evident, they're long-term and they're expensive commitments for any funder to take on. So you don't do it lightly. The proposal, if it's a new one, needs to be relevant to the population, the needs of the population currently, and there needs to be space in the landscape for the study to exist. So we don't want to duplicate studies that are already working, where we're just generating more of the same data. There needs to be a niche for the study. And then once you've started a study, they're incredibly difficult to stop, because there is a feeling we've invested so much to get us to this point, and there can be a tendency to duck issues of not recognizing the opportunity costs of continuing to fund something when it's really not delivering for you. So you have to be very disciplined as a funder in A, deciding when to start a new one, and B, deciding when to stop an old one, because neither of those decisions are particularly easy. We have internally other challenges, which is I mentioned that the research boards have their own budgets, and we have to get ownership of these studies by the research boards, because otherwise they won't fund them and they won't agree to put money into them. And one of the difficulties there is that, as I mentioned in the next bullet, for the research boards, looking at a cohort or a longitudinal study, which is really almost an infrastructure investment, and comparing that to maybe a 3-year project grant, one is very much cheaper. The project grant is very much cheaper than the population study. And also there are some very tangible benefits, and there are tangible ways of assessing the proposal and deciding how good it is. Whereas an investment in a population study is often sometimes a bit of a leap in the dark. You never know where it's going to end up, and particularly not if you're funding one for 10 or 20 years or even 30 years down the line. So you've got to balance the kind of here and now and the tangible assets of a research grant, focused research grants, against the promise of what might be delivered in the future. And again, I'll hopefully come back to that. And then there are issues, important issues about financial planning and how we make decisions in a timely way, and when there's a need for a particular new study, that we get it going and get it off the books as quickly as possible. So to facilitate the process of assessing the applications, we've come up with a two-step design. So we encourage whether it's a renewal or a new application, we ask the PIs, the investigator team, to discuss the application and flag up in good time with the head office so we can do the financial planning part. We've decided that we pull the research out of the applications for LPS, and that the application should just be for core infrastructure support, and that's an important development. Of course, it makes it harder to assess by the boards, but it means that we support a core, and then that core becomes a platform for researchers to come to that platform and do their research and prosecute their research in the way that Biobank works with researchers all over the globe to prosecute its research that way. So we've set up a strategic advisory panel which provides feedback to the MRC board. The board has ownership of the decision. The board has the budget, so that's really important. The board considers the outline at the outline stage, and it takes on board the comments from the strategic advisory panel and makes a yes/no decision about whether to go forward or not. And it's really important for investigators not to waste their time on taking forward to full applications studies which are, really don't have any chance of funding. So it's a fail early, fail cheaply type model that we're trying to generate here. And also to get the boards engaged at an early stage to make sure they recognise this is an important thing, they're part of the decision-making process as we go forward. And then the applicants, as you can see, have got 12 months to submit a full application. Here's how we try and get the strategic advisory panel and the boards to work in harness together. So as I mentioned, the strategic advisory panel look at the overall strategic need for the study in the wider landscape, and I'll come on to that in a minute. They look at linkages, collaborations with existing studies. They look at infrastructure and access arrangements to make sure that once the platforms are developed, the research community can use them and there are no impediments to that use. They look at whether there is any research involved in the application and whether that's just proof of concept or that's more tangible research. Proof of concept studies are allowed in the application. As I say, evidence of value to the wider community. The research boards then look at it through a slightly narrower lens, which is thinking about it in terms of their portfolio and the opportunities that the platform would have to deliver research that the board might be interested in funding further down the line. So that's the complementary nature of how we do it. It's a long time ago now, actually, in 2014, we produced a kind of doomsday book, a sort of catalogue of all the cohorts above 1,000 participants that were in the UK. Here's some of the data that emerged from that. We're still using an updated version of those data today to when we look at the landscape and we think about, is there a need for a new study? Is there a continuing need for an existing study? So these are the sort of things that it forms. It was quite interesting just to, UK is known for maybe Biobank and some larger studies, the Million Women study and so on and so forth. But actually, lots of our studies are relatively small. 30 or 35 of them were identified that were, in less than 25,000 participants. A lot of them followed up for quite a long time. So we've got, here's some of the information that you can glean from exercise of having just done the survey work, which helps inform what decisions you make. So numbers of cohort participants, you'll see Biobank and Million Women are off the scale, so they've been taken out of this graph, but it gives you some idea with the cohorts mentioned below. Length of follow-up in years across there, so that gives you some idea of what we've got. The numbers of participants by age and sex, which is helpful if you're thinking about, for example, do we have any studies in looking at child health and adolescent health? And those then provide incentives for filling gaps and identifying a strategic need for a new study. In addition to that, we also set up a cohort directory so that the community and other funders have a list of studies that they can go and check. So when you want to work with a particular study, or you want to see if there's something you can work with, or you want to check your application is not duplicative of an existing application, you can check the MRC cohort directory, which is available online. It's not a very sophisticated directory, but you can do a very quick search. And then when it comes to renewing, and I'm nearly there, when it comes to the renewal of funding, the kind of things we're looking at are access data. So how widely is a particular study being used? And if you look at the top left of this slide, you can see I've taken away, this is real data from a study, a birth cohort actually started in 1990. But you can see the number of access applications that are coming into that study. So we can see that the community are using this, that the study is responding to a particular community need. That's really important. We can also see that the outputs are coming out. So you've got publications and citations that are shown there. And you can sort of see the scientific domains that have been presented where the cohort is working with different groups of scientists and different range of scientists. And if you look at the bottom left, there's and I think it's a salutary, it's an important lesson for both funders and investigators alike. This study was started in the 1990s, and if you look at the first 10 years of funding there, very little output. And so I don't mean to have a message of despair, but you know, when you're into the cohort funding business, it's a long-term game. But you can sort of see, if you want to scale the higher peaks of productivity, you have to start in the foothills. So that's a very quick, hopefully a useful perspective from a funder, and I'll be happy to take any questions at the end. Thank you.
Thank you. You all hear me? So thank you for the invitation to come here to Singapore. I've been here for many years. I've been here for the past 20 years. It's been exciting to see the evolution of what's ongoing here in Singapore when it comes to cohorts, genetics, and all the other things. I just wonder, I work at the Karolinska Institute. There's like 12, 13,000 employees and students. I wonder if I gave a presentation on biobanking at Karolinska, if I would attract this number of this audience. I don't think so, I'm not certain. Anyway, there we have our new, this is our new layout that we are supposed to be using. I think a little bit too prune heavy, nevertheless. So I'm a medical oncologist by training, an epidemiologist. I've been into, maybe I should use that as well. So I've been into this kind of research using cohorts and biobanks for very, very long. And I will like to give you a presentation more of from a user perspective. So I was heading the Department of Medical Epidemiology and Biostatistics, where we have the Karolinska Institute's biobank. So I was heading it for a while. I'm not hands-on, of course, but so the Karolinska Institute's biobank, as I will tell you, is a core facility that we could use at the Karolinska. But I will also use it somewhat from a user's perspective. Okay, so this is, is this the one I use? No. Oh, goodness. No?
The bottom button. You need this one.
Oh, thank you.
And then this one is the pointer. Thank you.
Okay, So I will talk about the biobank today. I will talk a little bit about my own experience using the karma intervention study, which is one of our studies, and also what the Karolinska Biobank will be doing tomorrow. So what are we doing today? What is it? So it all started in 2004. That's approximately when I came here to Singapore the first time. We invested in data systems and LIMS systems, and in Europe and Sweden we have a lot of legal issues to deal with when we set up a biobank. We need informed consent. We need to meet. Well, in those days we didn't have GDPR, but now we have. So this is, and I will tell you about this. This is the biggest challenge actually. We had the first withdrawals in 2006, and we set up a big cohorts in 2010. My cohort, the Karma database, is one of them. That's breast cancer. Then we have equivalently big cohort on prostate cancer. And then now we are ready to take the next step. So, and I will also tell you that when I told the people at the biobank that I'm going to Singapore to lecture about the biobank, they got really excited. No, could we come with you? So, no, too expensive. So anyway, oh, sorry. A little bit more careful here. So the number of donors is 750,000, and we are approximately 10 million in Sweden, which means that the KR Biobank, we have 7.5% of all the inhabitants in Sweden in the biobank. We have approximately 8 million samples, and the number of papers, I asked them about the number of papers over the years. They couldn't give me a figure, so I counted my own papers. So for my group, it's more than 200. And here comes the number of sample types. And they gave me the figure of 56. So I said, what is there? That's plasma, there's DNA, saliva, what do more? But then they had hair, breast milk, umbilical cord, blood, bone marrow, and so forth, number of tubes, and so. But most importantly, the sample of withdrawals. So every year there are 70,000 samples withdrawn, and that's the most important thing, that you also use a biobank, because funding comes mainly from the Karolinska Institute, from the university, and they are frustrated. They say that we only withdraw 10% of the biobank each year, which we think is quite good, but they think it's underusing the biobank. Anyway, it's the same. There we go. So quickly on storage. Room temperature for filter paper, saliva, DNA. This is an image they sent me. They are so proud of all this. And of course, what this is the most important thing here is that this also drives cost. So the cost of maintenance, the cost of running a biobank, the cost of having a cohort as we have and linked that to biosamples. So we have most of our samples in plasma, serum, and DNA. This is what we have mainly. So it's quite expensive every year, and when we don't use it, then it becomes really, really problematic or frustrating. I will touch upon that in the end. So what is biobanking? And to me, biobanking is not about freezes and LIMS systems only. I see that you take photos, and then please, could we do like this, that we share my presentation? Should we? So feel free to continue taking photos, but... oh, my golf swing. So, 3 important dimensions: regulatory, data, IT, laboratory. So for each sample, these are the 3 dimensions that we think about. And for us, as running the trials or setting up the cohorts, this is the most important, because it's so many laws, so many biobank rules and regulations that we have to follow to handle and prepare human samples, secure storage of samples, guarantee traceability of samples, send samples for analysis. And as I conveyed to my British colleagues and friends, it's just to send samples now into a country. I will not tell you what country it is, but they ran into Brexit recently. and it's been a challenge. It's not such a challenge to send samples from us, from our biobank, to the friends at the university. I will not mention, because I will not mention the name of the country, but so it is problematic. So regulatory aspects: adherence to biobank laws or regulations, applications to authorities such as the Medical Products Agency, which is like the equivalent of FDA, ethical board. This is also becoming more and more complex, and the rules and regulations are changing. We have new rules now in Europe since January, which not even the specialists know how to handle. So this is a big problem. It's a challenge. Then we have the biobank agreements, the sample agreements, all these things. Then we have the data, the laboratory, the LIMS system, the traceability that it brings, the data filtering and visualization. I will show a little bit about that, the automation, referral databases integration. This is what they help us with, they could help us with. And lastly comes the lab part, sample type, tube type. So this is just to underline that to me, biobanking is not only about the freezers and the LIMS system. So there are 40 employees at the biobank. There are 10 out of these who work, 10 out of the 40 employees who works actually with the laboratory, with the samples. So I'm running something we call the Karma Cohort, which is 70,000 women that we follow prospectively. But using the cohort, we could actually invite women from the cohort to enter into our trials. So the Karma intervention study becomes Charisma, and this is an example of how the biobank could be used. So you might know that there are endocrine drugs that we use for breast cancer patients to reduce the risk of recurrence of the disease. But you could take the same drugs and give it to perfectly healthy women. It reduces the risk of breast cancer by 50%, which is mind-boggling. And it's been accepted in the UK and the US to be used for prevention. This is tamoxifen. The problem with tamoxifen is that it brings side effects, and very few doctors are willing to prescribe tamoxifen to perfectly healthy women, and very few perfectly healthy women are willing to take tamoxifen if they know about the side effects. So what we wanted to do was to conduct a dose determination trial and test 5 doses of tamoxifen and placebo, which we did, and I went to my friends, the statisticians, and said I would like to test 5 doses and placebo. This is the accepted dose given to patients, and I want to see how many cancers they develop. And they started calculating and came back with the biggest smile I've seen and said, you need 154,000 people per, which is not doable, of course. But instead of following these 6 groups for 5 years and see how many cancers they're diagnosed, you could actually use as a proxy for therapy response density change. So mammographic density decreases in women who respond to therapy. And then we could, instead of doing a 5-year trial, we did a 6-month trial, and this is what we did. And it's been published. Anyway, we also wanted to then collect a lot of stuff, polymorphisms. We want to look into DNA, safety, plasma, metabolites of tamoxifen, proteins and so forth, and receptors in perfectly healthy tissue, and see what tamoxifen brought. So this is what we wanted to do. This is what we came to the biobank and said, this is what we would like your help with. And then they immediately sent us off to, this is Swedish, since that's a catalog of stuff that they provide, and this is what they provide more or less, not in detail, but anyway. So after discussion, this is what we want to do, primarily DNA, plasma, we want to do it repeatedly, and they came up with these are the things that we want you to help us with. Anything from planning the studies, ethics, regulatory advice, referrals and registration, I will talk a little bit about that. Sample preparations, of course, DNA extractions and sample withdrawal. This is sort of a core of a biobank. But also use informed consent forms. So what the biobank now provides us with is our consent forms that we could use, not only for our study, but for other studies. So firstly, the informed consent. So nearly all data sets that are using the KI biobank, they use the same, more or less the same informed consent form. So what we use, that is the study information that's separate, and then you have an informed consent form, very standardized. It's signed and then it's scanned and stored in the biobanks. We have, because this is extremely important, what we have consent for. Then we have the referrals. So here it says, well, now that's tissue, this is blood. So this is also standardized. You have the barcodes, you peel them off and you put them on the tubes and everything is tracked and you have an ID number that follows the individual. So this is also the way we do it. So we have probably conducted 5 studies, and these forms look more or less the same. It's just that we changed the logo for the different studies. So this is how it looks. And when I discussed it with the head of the biobank last week and said, do you agree on this? He said, well, this is a very nice way of looking at it, because this is how it goes. The regulatory issues, challenges, consent, inclusion, phlebotomy, transport, handling, And the first part, the biobank is helping us. The second part is us. We are approaching the women, we are recruiting them, then comes biobank back, and then we do the analysis and withdrawal and send off the samples to whatever laboratory we collaborate with. So this is an integration that before I prepared this presentation, I haven't really thought about it, the way we interact, but that's what we do. So finally, ending up with the biobank tomorrow. So the problem now is that I have to go to the biobank in order so let's say we collaborate with a group in Cambridge, with Doug Easton, the so-called Breast Cancer Association Consortium. Every year, in the Karma cohort, there is approximately 200-300 new cases, unfortunately, of breast cancer, but we want to send the DNA to Cambridge because they've been doing the genotyping since 15 years back. But then I have to go to the biobank and say, for how many of these 300-400 do we have DNA? What's the concentration? What's left? What's plasma? And so forth. So they want us to be able to do that without using them. So how could I, as a principal investigator or any external researcher, get access to information? How could information be transferred to researchers without the involvement of the biobank? How could transparency be increased? How could samples be better used? So this is something that I've been thinking of and working with for the last years. So they have something that I'm very proud of called the Kiwis, whatever that stands for. I assume Karolinska Institute, BIS, I don't know. Anyway, here you search your search criteria, you enter whatever you're interested in. Mainly this is for PI, so I enter the Karma or Charisma, whatever, to see what I wrote there. And then I get back number of participants, ID numbers, number of types of samples, and so forth. And I also have, which is quite unique, and they're really proud, to add information such as diagnosis, medications, and so forth. So I could actually enlarge it. But this is not for you. This is for me as principal investigator. But if you want to look at it, then this is something that I'm really excited about. I don't know if it's the color of the layout that I'm most excited about. So the Karolinska Biobank Sample Collection Catalog, beta version. So right now we have 220 studies and different sample types, as I told you about. And then I said, well, you gave me 8 million. This is not 8 million. Then they realized it's a bug, but they said it's a beta version. Anyway, so what I did was that I entered bone marrow, and it turns out there's one study that actually has access to bone marrow, but I got back to her and said, you can't have bone marrow for 16,000 people. No, we don't have bone marrow for 16,000. There's another bug, so anyway. But anyway, this is what, to show you what we have, or the biobank has. And if you are interested, you could have access to samples, no problems whatsoever, as long as you fulfill, as long as, I would say that if you come to me and say that I would like to study breast cancer, we could provide you with the phenotypic information, we could provide you with the genotypic information, we could even provide you with DNA from the Karma cohort. But if you say, I would like to study the risk of myocardial infarction in using the Karma data set, I would tell you that we don't have informed consent for that. So that this is probably the first question that's put. Anyway, it turns out that 157 studies have DNA. If this is correct or not, I don't know. But this is what they're working on now. So it's one system for the PIs to have detailed information all the way down to concentration, but also one system for you guys to browse whatever we have. And then, of course, what I did was that I entered the study name Karma, curious and see. So it turned out that we have these are different tube types and number of samples. So we have 1.6 million aliquots. The Karma cohort is 70,000 women. And all this looks fine, doesn't it? It's continuously matched to everything. And currently there are 2,400 women diagnosed with breast cancer. But, collected 10 years ago, or more than 10 years ago. So this is also the problem with cohorts that I didn't really spend time on, but I could probably give a presentation on. So what are we going to do with all these samples? We have 16 plasma aliquots from a large number of women that do not really contribute. And the older the samples get, the less the contribution. Because if someone, again, wants to study risk of breast cancer and look into hormones or proteins or whatever, yeah, good thing, but there are continuously women diagnosed with breast cancer, but the collected samples are 10 years old. So it's not likely that we will find proteins. It's not likely that we will find the equivalent of a PSA in 10-year-old samples. What we do, though, which is slightly outside this, is that we continuously collect mammograms. We believe that mammograms are, if you want to really be able to identify women who will be diagnosed with breast cancer, mammograms in the short run, not in lifetime risk, but 2-year risk, then mammograms and features in the mammograms. So that we collect, so we continuously collect. So every month we add on 20 to 30,000 mammograms for these women. And that's important. That's the challenge, and that's the difference between having plasma, DNA, whole blood backup that are 10 years old to have mammograms that are continuously updated. That's a huge difference. So very quickly, I'm running out of time, I think. So the biobank is much more than a freezer. It's a core facility, and as I said, regulatory issues, legal, ethical, IT. KIBIS is a PI support system. The sample collection catalog is a metadatabase for anyone to use. Doesn't give detailed information on participants, but the possibility to browse the content of the biobank. So, in my own view, so without the Karolinska Biobank, we wouldn't be, there was no possibility for us to run, to gather within, in 27 months, we got information on blood sample from 70,000 women. That will not have been possible. So this is a really professional group of people. And at the same time, as the biobank was set up, there was a core facility for genotyping and sequencing. The difference between the biobank was that the biobank consisted of people who had been researchers but were not doing research anymore. They were not writing papers, they were not writing applications. In contrast to the genotyping facility, because that was run by people who were still doing research, which meant that that facility didn't work at all because they had so many other obligations, they had so many other things to do. And if you didn't have good connection with the researchers in the genotyping facility, it didn't really work. So I've been working centrally at the university. I was constantly advocating that you shouldn't have active researchers running core facilities. It doesn't really work. That was a really provocative statement. That was, ooh, you nod, you agree, and they didn't like me. What I said. Could be other reasons, I don't know. And we would not be able to collaborate, retrieve samples, send them to others, and share data. And from a biobank laboratory sample preparation perspective, our trials have been comparatively easy to conduct. The cost is a drawback. So this is one of the drawbacks, and the way we're thinking now is that just to maintain a database is extremely costly. So what we want to do is to expand the consent to be able to allow Karma to be used for other things than breast cancer, and maybe then collaborate with others who are willing to pay for our services and the samples. But that's something that's ongoing now because very many of the holders of large cohorts at the KR Biobank have problems. We are struggling every year, so we pay maybe 200,000 Singapore dollars a year just for rent, which is a lot of money, especially when there's no real funding mechanism. You can't go to the equivalent of Cancer Research UK or the Medical Research Council and say that I would like to have 200,000 Singapore dollars for rent on my samples. And I said, well, they don't understand the concept. So that's encouraging to listen to you, Joe. Okay, so thank you very much. Yeah.
I think he's here.
Where's the down button?
This one.
Well, good morning. So I'm Andrew Morris. I'm from Scotland. Who here has been to Scotland? Thank you. Please come back, because but it's great to be in the best small country in the world. So, although I remember I first came here in 1985 as a student. Who here wasn't alive in 1985? Oh dear. That's a bit scary. But every time I go back, I'm 10 kilograms heavier. So that's a challenge. But we've had a great few days, and it's a real privilege to work in partnership with you and learn from you. So today, I'm going to try and convince you that we're at an inflection point in biomedical research, cohort development, but also innovation and healthcare delivery. And that inflection point is driven by data science. And I'm going to try and convince you that we have a collective responsibility to harness this new capability in a trustworthy way for the benefit of patients and populations. So that's what I'm going to do. And I'll try and make up a bit of time. So I'm going to talk about three things: the pace of change, secondly, gearing an entire country up for health, innovation, and research. We want to see a convergence of care and research using data science as the catalyst. And I'm going to suggest that it's time, well, Singapore is bold, ambitious, and enterprising, but let's do it for data science in healthcare. So that's the script. And this was Joe yesterday, enjoying your sights of Singapore. So why the pace of change? So I was born in 1964. There were 3 billion people on the planet. As of last November, there were 8 billion people. The global demographic is really quite scary. In my short lifetime, the number of people living on beautiful planet Earth has gone up 250%. That is associated with inequalities in health, which is a major challenge. But also, it was Bill Gates who said, I want you to look carefully at that picture to see if you can recognize anyone. It was Bill Gates who said, we often overestimate what we can achieve in 2 years and underestimate what we can achieve in 10. Can you see anyone? See, that was me on the ward. You see that? Don't sound so shocked. This lady was Esther. She had infective endocarditis. So I remember her very well. So even in my short life, and this will happen to you in your lifetime. So what didn't we have when I was on the ward? The Glasgow Coma Scale. MRI. We didn't have MRI in my early days, 1984. Statins. We didn't have statins at 86. Laparoscopic surgery. I often suggest this is why you can never find a surgeon in a hospital. Smoking ban in public places, and more recently immunotherapy. So things are going to change in your research and clinical lifetimes, but because of we don't anticipate it. But what we're going to see now is an exponential increase in the pace of change. Does anyone know where that, why, where's that, you know? Davos, immediately. Have you been invited? No. So, World Economic Forum meets every year in Davos, and they talk about the fourth industrial revolution, because we're seeing a fusion of physical sciences with biological sciences and health sciences. And the challenge we have is to harness this in a trustworthy way. Because what we're seeing in computer science, are there any computer scientists in the room? right. It's because I define data science as the interface between math, statistics, computational science, and domain. And our domain is obviously healthcare and biomedicine. Any mathematicians in the room? One. Why? Good. Any statisticians? One. Two. Right, so when I come back in 10 years' time, we need to see math, statistics, computation, and domain. Because if we get that chemistry right, we'll do great things. Because in computational science, what we've seen in the last 10 years is remarkable progress in sensors, robotics, natural language processing. But also we've seen a confluence of these technologies. They use them together to create new products. And we shouldn't anticipate this pace of change. Let me illustrate that to you. Exascale computing. So exascale computing is 1 billion computations per second. And this is, do you recognize anyone there? That's one of our many former prime ministers in the last 6 weeks being shown around the supercomputer. But exascale is here. The Internet of Things, 11.3 billion things are connected to the Internet in 2021. It'll be about 30 billion by 2030. And this will be the future of epidemiology and cohorts. And here's an illustration which is very topical. ChatGPT, who's used it? Yeah, amazing, eh? So this was Spotify, which we love because it's Swedish. Spotify took 150 days to accrue 1 million users. It took ChatGPT 5 days. Now, I gave a talk in Dublin talking about ChatGPT-3. This was in March, and I said, oh, well, you know, ChatGPT-4 will be around probably Q4 23 or 2024. It was a bit embarrassing because they launched it the next day. But GPT-3 had 175 billion parameters. So this is sort of statistical natural language processing. Going back to my last slide. GPT-4 is about 170 trillion parameters. So the scale of this is phenomenal. And as you know, it's being applied to computer vision, textual and imaging data. And this is coming to medicine and healthcare. So that's one thing, computation. The other thing is I would really like to work in partnership, because we think that Scotland needs to be a single research site. And I would argue that Singapore should position itself as a single research site, because scale is important. Who's that? Joe, I hope you know. This is Rory Collins from UK Biobank. So this is Framingham's study of 5,000 people. This is mortality and blood pressure. And if you screw your eyes up, you sort of see a relationship. 5,000 people, 50,000 people, UK Biobank. So scale is going to become increasingly important, especially as we take common disease and disaggregate it into a cluster of rare diseases. So scale is going to be important. So I'm trying to convince you that data science is important for 4P medicine. This is Leroy Hood, who helped to define the genome. You know, medicine that's predictive, preemptive, personalized, and participatory, which I quite liked. But also medicine has to be, and we have to be aware of the world we live in. So sadly, I talk about 4P society, which is Putin, pandemic in the UK, public sector unrest, and pressure of inflation. Because biomedical research is expensive, and we've got to use economies of scale. And if we've got data that we can link that's routinely collected, as Pers said, 20,000 mammograms a month. If we converge care and research, we can use those data to really improve patient care. And if you look at international best practice, and again, I put a Swedish Jönköping. If you're sick in Europe, you want to go to Jönköping, because they're very good at treating. Are they? It's a boring. So come to London. Okay. Because if you look at the data as infrastructure at these high-performing health systems, at the macro level, at population level, at the meso level for stratification of patient, and at the micro level for patient, data is infrastructure. And that's key to future cohort development. So I hope I've shown you that we're at an inflection point, but progress is slow. We're really, why is it slow? We can't access the data. Who here has had a challenge in accessing data? Yeah, about 50% of folks. It's confusion, caution, and inconsistency in data custodians. And, we in biomedicine don't embrace computational science. Go and befriend a computational scientist, and you'll do great things. Because we often play catch up with technology, and also demonstrating trustworthiness with the publics to demonstrate we're using data in a good way. Because I anticipate we will move from a this is classical biomedical research. I'm a researcher. I know someone who's got a data set. I have a bilateral relationship with them. But actually, anyone who's got a good idea should be able to access data to really drive innovation research for public benefit. So I think we're moving towards data ecosystems where many data sets should be accessed by many researchers in a trustworthy way to allow the power of these data to be unleashed. But to do that, you need systems. And we're going to hear this from Mingshi in a moment. Because unless you've got the connectivity, the governance, the policies, the standards, the benefit sharing sorted, we will never mature this sector. And we will still be inefficient and actually not good value for the public dollar that funds our research. So I'm going to argue that we should think about data ecosystems that link information together. So we're trying to do this across the UK, and it's a bit of an experiment, and we're not there yet, but I just thought I would show you how we're trying to do this. We've set up a national institute called Health Data Research UK. It does what it says on the tin. What we're trying to do is unite all the UK's health data on 68 million people to drive discovery in anticipation of the fourth industrial revolution. So can we curate data, link data, 68 million people, and then in a very fair way make that available? And I would credit the funders who came together 5 years ago to say, let's work in partnership. Because often funders do their own thing. And MRC were there as part of UKRI, but it's a UK initiative, and more recently we've got other support and funding. So can we unite the data on the entire population? Now, key to this is we didn't want to build a building. The easiest thing to say, we'll build a building. Because we got about 80 million Singapore dollars initially. But we didn't. We said, we'll work with the expertise across the UK, and we will set up an institutionally agnostic institute to try and drive collaboration at scale. Because this is a people project on collaboration, demonstrating trustworthiness, scale, diversity of people, data, and delivery approaches, bringing these sectors together and developing these core platforms to make your research experience a lot easier. So we sit in Wellcome in London. We've got a board, very strong board, because this is a data ecosystem. We will never have a data lake for the UK. And when I saw that, I thought, I think I'm going to go and play golf. This is all a bit too difficult. And I was depressed by that. But then I went to Holland, and they're just the same. And I would argue Singapore will be the same, because you'll have data here, data there. So the key is the interoperability. And the country that can join this up for multiple purposes will do really well for its citizens, but also in biomedical research. So that's where we are. We work across 38 universities, over 100 NHS organizations. We have a distributed leadership team from across the UK. We learned from the pandemic. We have fortnightly meetings by Zoom just to support each other at scale. Because what we want to do is use routine data and research data to do three things: diverse data, longitudinal sequential measurements, and scale. on the entire population. So how's it going? So you were going to hear about trusted research environments from Mingshi. So we've adopted the 5 safes. We've got a network of TREs across the UK, which beginning to talk to each other. We've made 750 UK data sets discoverable, just as Per talked about the Karolinska Biobank. We've got over 500 research projects, but key is the partnership. We've got 70 of the, all the big data controllers saying we subscribe to the FAIR principles as part of this ecosystem. And that in the first 5 years enabled about 2,500 papers, you see. So it's, it's beginning to demonstrate utility. But I thought I'd give you a quick, have I got time, a quick case study on COVID, because it's still a major challenge for humanity. So at the beginning of COVID in the UK, the academics, the policymakers, the doctors, the service delivery folk all wanted to use data, but they all did their own thing. So what Patrick Vallance, he's the equivalent of Cho Chan in the UK, said, we need to join this up. Can we map the data? Can we put the infrastructure and services in place? And then can we make it fair for all COVID data in the UK? And it was really messy. And in the early days of June 2020, this was a bit of a map of COVID data. It's very busy, but this is Northern Ireland, Wales, Scotland, England. So that collectively 68 million people. But then a year later, you can see we'd catalogued, metadataed, made the data available at scale across the UK. And it's not just biomedical data. So we had testing, viral genome. We had some whole host genomic data as well. Death, surveys, but also what did the public think of behavioral science, labor force. So we'll be able to create an integrated data set. So examples of where that was really useful. So this is Scotland, very similar population to Singapore. We had a real-time data set that linked primary care data, vaccination, COVID testing. So you had the end-to-end journey of COVID, basically. And within 8 weeks of the vaccine being launched, we were able to show that a single dose of AZ and BioNTech was actually sufficient to reduce hospitalization by 85%, 94%. And that actually gave us confidence to reduce the dosing interval, as was published in various places. And we used the same approach for vaccine effectiveness, variants, vaccine waning, vulnerable groups, vaccine failures escape. And this one I'll point out because we worked with Brazil on the AZ vaccine to demonstrate the waning of vaccine at scale. And it's very powerful, but if we can do this for COVID, why can't we do it for cancer, cardiovascular, mental health, all the non-COVID pandemics that we wrestle with? Here's another example, were the vaccines, because all medicines risk-benefit. There were some reports of vascular thrombotic events. So this is on a population of England, 57 million people, showing the importance of linkage across different data sets. And what the team did under Kathy Sudlow was to look at the risk of major vascular events in this entire population. And there was a thrombotic event on the brain called VIT, you may remember, and we're able to look at the differential impact of AZ, Pfizer on VIT, but then compare that with the thrombotic risk of COVID itself. So, we talk about long COVID. So again, on 48 million people, what was happening a year out? And this was in circulation recently. So what do we mean by long COVID? And it must have been important, this study, because it made that major medical journal called The Sun. Aftershock, urgent warning to anyone who's had COVID in the last year over killer complication. So I wish my manuscripts had such exciting titles. You can also use it for trials. So the recovery trial, dexamethasone, we didn't have the traditional approach of having a squadron of researchers looking at ascertainment of outcomes. We use routine data. We set up a trials hub to enable the feasibility, eligibility, and ascertainment of outcomes. And recovery used routine data at 28 days to assess effectiveness. And that was a major record linkage exercise across the UK. So these were the data sets which were used, driven by a clinical trials data science hub called Digitrials under Marion Matham to ascertain recovery. Recovery would not have worked without routine data. And arguably, it's the most effective COVID trial internationally. They estimate dexamethasone saved 1 million lives globally. But then you can pivot this infrastructure to other things. So we have national prescribing now on 68 million people, and you can link that. So we're now looking at the effect of especially valproate and pregnancy and how guidelines are being adhered to on a national scale using routine data. And we looked, this was in Nature Medicine recently, the impact of the pandemic on non-COVID harm, cardiovascular disease. And 500,000 people in the UK did not have incident intervention for cholesterol hypertension management. And we've just published that has resulted in an additional about 20,000 events in terms of cardiovascular events because of, we basically closed down the health service. It became a COVID health service. And that's what Sweden didn't do. So we've learned for next time. So it gives you an idea. Mingshi and I talked about this. This requires health data scientists. And I'd encourage you all to be T-shaped, be great in your domain, but think, should I learn something about coding or computer science so that we can try to bring these disciplines together? And we're trying to train, we want to train 10, 20,000 people in this discipline. And also we're trying to support groups who traditionally have not majored in health data science. So we have a very specific black internship program, which has been fantastic. And already they're becoming leaders in their field. And finally, public interest. So can we work with the publics to inform data and research? So we have a public advisory board, which is a golden thread through everything we do. And they test us in terms of trustworthiness, being honest, reliable, and competent with data at scale through our values. So finally, have I got 2 more minutes? Is that okay? How do we scale this? So I think build it and they will come is not enough. So we need a major focus on computation, data engineering, and cleaning of data, because these data are really messy. And this issue of public trust must be continuously earned. So as we look towards our next 5 years, we're doing 3 things across the UK. Assembling data infrastructure and services, so-called TREs, supporting a number of research driver programs, and thirdly, trying to work out how we can incentivize the system to work as teams, locally, regionally, nationally, and internationally. Because this requires team science, arguably on a scale not seen before. So this is our data ecosystem. So what we're trying to do is connect data custodians to researchers and innovators. These are the data controllers. This is the gateway. So it's a bit like the Amazon marketplace to the world. But then you've got these pillars of expertise around technology, trust, governance, transparency, standards, and capacity building to link it all together. So that's where we're putting a lot of effort. So assembling the infrastructure, data, and services. And I call this the hard stuff, which isn't that exciting at times, but everyone thinks it's someone else's problem to sort out. But you need to do it at the national scale. And part of that is having a network of trusted research environments, safe, secure, project-specific workspaces in the cloud, allowing researchers to analyze multidimensional data. And these are the data that we are accruing through our data strategy: national data, regional data, administrative data. So this is like government data. And then increasingly personal monitoring data, environmental, and then the research-specific cohorts. It's a data ecosystem. And I would argue if you've got great cohorts, wouldn't it be fantastic imagine the research you can generate if you can link it to this stuff. To do that, thirdly, we think you need research driver programs, and we've got 6. So we've got one on sort of COVID, pandemics, one on medicines across the UK, social environment. But the nature of the design of these is important. Firstly, you want to answer a really burning research question at national scale and projects that single institutions can't do themselves. But secondly, they strategically guide the development. They clean the pipes of the infrastructure and services, and they must leave an asset that other folk can use. And then finally, and because we've learned so much from Mingshi, from YY, from Schuling and Wendy and colleagues, because I think that globally, in the pandemic, we really needed to follow the pandemic globally. So we need to create a mesh network, arguably of national institutes where you can run experiments across the world, not only in infectious disease, but in other diseases. So we're doing this regionally, but also globally. And in the pandemic, we worked with the Gates Foundation and Minderoo, who are Australian, to support 12 driver projects. It brought 135 researchers together across 19 countries. And it really did create a global community, which was fair and productive. So to finish with a Marie Curie quote, we're in the foothills of where we need to be in data science. We've learned a lot, but we've got a lot more to learn. I think the mission of seeing a convergence of care and research underpinned by trustworthy data science is good for healthcare, good for population health management, good for planning, and good for research and innovation. But one never notices what has been done. One can only see what remains to be done. I'll finish with Thomas Dorber, who was the architect of Framingham. Participants were treated like gold. They must never wait, must be thanked by everyone they interact with. So at the end of the day, we're the privileged recipients not only of public money, but of data of citizens, and we should never forget that. And finally, it's about team science. This is from the Wall Street Journal. The new Einsteins will be the scientists who share. So support each other, be T-shaped, and let's do great things together. So thank you very much.
So it's always a bit stressful to be going right after Andrew. He scaled the mountain. We are really at the foothills. Should I switch to?
Did you need a
Yeah, I'll take that.
presenter? This one is next.
Maybe I'll just stand further from that. Okay. So very good morning, everyone. Very, very happy to be here. I'm Mingshi. I'm from the Chief Health Scientist Office, Ministry of Health. And today we're going to share about trust, which is our more small little effort in Singapore, an attempt to look at how we can help our data ecosystem and bring together different types of data to help our researchers in a safe and secure manner. So actually, a couple of years ago, before we started this, we visited HDR UK. And we sat down in a room and we listened to all the wonderful things that they were going to start off with. And we said, okay, look, we got to do something about this. And that really was driven by a lot of interactions with the research community, yourselves as researchers, as to the kind of challenges that you guys are facing when it comes to being able to access data, the long time it takes to do so. So in the last few years, what we have embarked on really is an effort to look at how we can set up a national health-related data exchange where we are able to bring together different types of data sets across institutions, across different data custodians in an anonymized manner into a safe environment for research analysis to be carried out. These were the challenges that you guys had fed back to us a couple of years ago as to the challenges that you meet when you are accessing data. That includes the long time it takes for you to set up agreements with different data contributors, data custodians, the lack of trusted third party to do so, the lack of interoperability of data because everyone is using a different data standard, and also the difficulty to access useful administrative data, which could reside in various ministries or government agencies. So what we have done with Trust was to look at all these issues. It's okay, I can circulate the slides later so you don't have to take them, but please feel free to take them if you still wish to. So what we've done over the last few years was to look at identifying a way in which we can do so in a systematic way. So we have completed our proof of concept. We have launched Trust. It's operational now, and you can access them. I'll give you the website later. But what we've done in the first phase was really to develop a pilot data sharing platform which can enable that sharing to happen. We have worked with all the key public research institutions to establish the rules of engagement and also the access by researchers. We have also demonstrated the ability to bring together some of these data sets that you see here from both the research community as well as with the government agencies. We're currently now in phase 2. We're expanding the types of data sets. I'll show you what we have currently. And we're also starting to pilot access by the industry before we scale this up further with more data sets that we made available. I'll skip the boring parts, but I think what I will share about is some of the use cases that we have been working with. And again, very grateful to the research community for providing the data sets and also the data scientists themselves who has helped us in working through this. They are important because they help to test the platform, the ability to do the linkages, and also the boring parts, right? The legal, the agreements, and all that, and whether they actually work. So in the first use case, what we've brought together are the data from the National Precision Medicine Program, as well as lifestyle wearable data and clinical data from Ministry of Health. And the first use case was really to look at how we can better enable some of the programs that Health Promotion Board is running currently in identifying high-risk patient segmentation and being able to evaluate some of their health lifestyle programs. The second use case is around genetic variants. So here working with the Precision Medicine Program to look at potentially pathogenic variants, identifying them in such a way that we can better intervene much earlier to individuals at risk. So these are some of the early data that has come out from the pathfinding projects, and thanks to Murray and Hong Kiet, who is working with us on this. So I think most importantly, before we dive into the details, I think I need to highlight that in this study, what we've brought together is really data sets across 6 different cohorts, 10,000 individuals with the data from the health ministries as well as from the Health Promotion Board and Precision Medicine Program. So this Marie's work, which was looking at correlation between what she has developed as PRS scores relevant to cardiometabolic health. And here you can see that the data linkage with the clinical data and the Health Promotion Board data sets, where the biomarkers often associated with cardiometabolic health has mapped very nicely to the PRS scores that they have developed. And I think this gives us more confidence in terms of the ability to do the linkages, as well as the types of tools and analysis that's within the trust environment available to the researchers. Another study that was done by, this is Juk and Yues and Wen Kyung's group, was to look at some of these variants of unknown significance. In this case, it was for familial hypercholesterolemia. And I think they've managed to identify some of these unknown variants that potentially exhibit phenotypes as consistent with FH. And in this case, supports the identification of potentially pathogenic variants earlier. There are also some early studies that came out when they looked at correlation between the data sets that the Precision Medicine Program has with medication data with MOH. And I think it also suggests that some of these patients with FH are actually not properly diagnosed or needs to be more closely managed. And so this is some of those important findings that we have been looking at and bringing back to the ministry. So as I mentioned, Trust Phase 2 is operational now. The website is live, and School of Public Health researchers under NUS, you are welcome to sign up with us, as your school has already signed an agreement with Trust for you to access the data sets. The catalog will be available online, and you can take a look at them. These are the kind of data sets that's made available at this point of time. In terms of real-world data, there's the clinical data sets from Ministry of Health, disease registry data, as well as various administrative data that is currently made available. The research data sets are still things that we are working on with the research community, but these are potentially what will be coming on board in the next few months. This is a very busy slide, but I think what we're trying to highlight here is that it's really an iterative process that we are having with the research community to understand your needs and your requirements as we develop this trust platform in phases with the tools that are useful to the research community. What we have now, what you can see in the middle, but we are slowly scaling that up in the next phase. Some of the things which I get asked by the research community a lot. So these are what we cannot do at this phase, at this point in time. The recency of our real-world data sets is currently 2 years, and we plan to shorten that to 1 year going forward. This has to do with the data source that we're bringing that in from. At this moment, we can only deal with structured data, but we're looking into unstructured data and images in the next year. And of course, to test federated analysis, which we are very excited about, with HDR UK as a potential partner in the next year. So we talked about the 5 Cs. I'm just going to touch a bit on the boring part, but we take data security, data use very seriously. We've adopted the 5 Cs framework, and to ensure that the use of the data is maximized while ensuring the security. So I just want to highlight that this is the Trust Data Access Committee. So all data requests that goes through Trust, we would be put through the Data Access Committee. NUS is represented by, I cannot remember who now. Okay, by Wijru here. But essentially, the role of the DAC is to look at the various requests that is put up and to assess their benefit and the social use and benefit of this research studies before they are approved. This is the journey that the users can expect when you put out a data request. And I think with School of Public Health as a member on Trust, you can actually put up a member account request on the website. And that's here. Once you have viewed the catalog, you can put up a request to the Trust Data Access Committee. And after which, the data that you have requested for will be provisioned to you in a cloud environment, which you VDI into that's hosted on AWS. And after which the exports, which are at this moment what we've proved for is for aggregated de-identified outputs, can be taken out with the approval from the Trust Concierge. So I think for many of users have also asked whether and how they can use it. So Trust operates on 2 models. You could either bring in your own data sets, which is this model 1. So you do not need to use any of Trust data sets, but it's more of a facilitator to bring your data together with your collaborators. The other model is where you wish to tap on the data sets in Trust, and we welcome that as well. And in this case, you would be able to link to the different types of data sets on Trust. We use the same type of anonymization and tokenization tools to enable that to happen, and the same rules apply in terms of the export rules. My next few slides is really to talk more to potential data contributors who are interested to bring their data sets onto Trust. What we have done with various data custodians in this case is to establish an upfront agreement. And this has helped us in making data much available in a much faster manner to our research community. So with an upfront agreement, any request that comes in future for your data sets on Trust, we have an agreed position on how they can or cannot be shared and under what circumstances they can be. The pre-agreement will, of course, cover all the important but boring bits about IP sharing, benefit sharing, to make sure that the data custodians are well protected and taken care of when it comes to that. And of course, through that, we really hope to reduce the kind of lengthy bilateral negotiations that would otherwise have to happen when each and every data request comes on board. So to the data contributors and custodians out there, what Trust hopes to do is to work together with you to improve the data quality and interoperability of your data. We have a data team that works with you to look at cleaning your data according to internationally recognized data standard OMOP. And the data sets at the end of the day are retained with yourself. You are still the custodians, and they will only be used and activated when there is a data request for your data sets. You retain sole use of your data during the exclusivity period. So in this case, you can decide who and how you want to share it with. What we have established with all the various research institutions in terms of our agreements is that for the access to real-world data, that gives the data custodians or data contributors a first dip into access to all the other data sets that I've talked about, the real-world data sets, which then allows them to link and fuse for their own analysis purpose. And then it allows us as well as the researchers to tap on this data set's post-exclusivity use, where it now opens up to a bigger group of researchers in the research community. So broadly, this is the framework that we have put forth with the various research organizations. And when we have worked through that with the parent organization, that's where we approach the different data custodians to bring on board the data sets. And I'm very happy to say that many of the cohorts have signed up to this, and we are progressively making that available now to the research community through this. This is the boring bit again, but while we've been asked many times as well in terms of charging, so for now, it's complimentary, free for use, though we want to eventually be able to strike a good balance between responsible use and widespread use of the platform. So there will be a charge for computation and storage costs, although the core infrastructure and development costs will be supported centrally through Trust. And this will also then be made available on the website for you to take a look at when you put up your grant submissions. So how to get started? As I mentioned, School of Public Health under NUS has already signed on the agreement. So you will be able to put up a data request with Trust after you have been given an account on the Trust website. And we have a data concierge team that's on hand to help you in terms of the questions you may have on how to use the platforms and how to onboard some of the data sets that you may want to bring into Trust for analysis. This is an important slide because we do realize that there are different levels of data science competency levels within the research community. So on one hand, we are looking at bringing in new tools to enable a more user-friendly kind of interface, a more point-and-click kind of interface. But at this point of time, what we do recognize is that there are certain user groups who would be finding Trust to be more user-friendly if they are familiar with coding with R, Python types of know-hows and ability to handle data science notebooks and some knowledge of cloud use as well would be very, very useful. But having said that, we do have a helpful group of data concierge team that's on hand to help any researchers who may not have had experience working in such an environment. So these are our partner institutes which have already signed up, and we are working with them progressively as well to make their data sets available on the Trust website. Okay, I think that's the last slide. See if there's any questions.
Thank you. That's been inspirational, I hope. Can I have a show of hands? How many of you have questions to ask? 1, 2, 3. All PIs, anybody else? All right, so we only have 30 minutes, and I'm also keen to make this sort of a dialogue between people, because it's not common that you have access to these people all at the same time and in person. So shall we invite them on stage? We can have a conversation. We can let questions start first. I mean, I can ask one question that is going to be very difficult, and all three of you, four of you can try to answer. But it's probably useful, I think, for all of you who make time here to ask some of these questions. Just their experience, what they did right, what they did wrong. I'm sure they're happy to share. Shall we do that? Okay. So can I have all of you to sit with us in front? Okay, I should start with one very difficult question, and hopefully we can answer that, and then we'll open it to the floor, at least at about 11:45. Okay, so these four people are actually builders. They build things for people to use. There's the funder, there's infrastructure, there's biobanking, and they talk about building all these things to be a resource, and at some point, in such a scale that it becomes a good service for everybody to use. Right? And we have our own example from our lady here, who's going to build it for us locally. So I'm going to ask the difficult questions, right? Who should build it? Who should pay for it? And how do we make sure that it's sustainable? Is that difficult enough? You can just feel free to answer.
I can start first, and then it's always the easiest to start first, because then people won't snatch your points. But I think the question of who should build it and who should pay for it, the answer will always be it's not me. But I think we recognize that at the end of the day, as a role of not just a funder perspective, but as orchestrator and a convener of many of these national level programs, we do have a role to help make the ecosystem a better one, and enable some of this to happen. So I talked about it in my slide just now, but I think at the end of the day, it's also a bit of a balance between encouraging responsible use of such platforms, while ensuring that they are used. So the cost cannot be so high and prohibited in that sense, but really a balance between that two. And I think engaging the users, engaging the funders early in getting them to understand some of this, putting them into their grant funding request will go a long way in getting that conversation started. Thanks.
Really good, complex question. Thank you. So I think it's a question about scale. So if, for instance, I started a cohort that consists of 70,000 individuals, we got funded from the Swedish Medical Research Council and a couple of other funding agencies. It was driven by PIs and the people in my group and those who were joining. The problem right now is to get funded for maintenance and the infrastructure. But if on the other hand you have efforts like the ones Andy described, it can't be solely financed by the ordinary route, the funding agencies, then I think that government or on the country level have to step in, because it's also different, because what we did, we had questions, we wanted to identify the risk and prognosis of breast cancer, very narrow, but you want to make it possible for anyone to use it. So then it becomes a different question when it comes to funding and who should pay.
So Shuling, great question. Right. First of all, we should ban the word build, because, and as an academic, I see an inclination in myself and others, because as soon as you get a grant, I'm going to build it myself. Whereas actually this is about assembly. There's lots of stuff already out there, and it's about assembling a set of infrastructure as a service, software, and analytical capability as a service in the context of whether it's the UK or Singapore. So I think assembly. Second thing is 10 years ago, this was all in academia, but now there's huge expertise in the industrial science base to actually provide these services. So what we're seeing is in the cloud providers, whether that's AWS or Azure, they're putting products and services on the cloud. So I think our responsibility across academia, policymakers, and the service is to be the intelligent customer to encourage assembly of products and services which are really useful to you. Who should pay for it? I think, like all infrastructures, it needs an initial capital investment, but at the same time, you should think around sustainability and have a service catalog or a business model. Because the thesis here, this should really help with the productivity of research and the reproducibility of research, which are both good things. So once you've demonstrated value of the service, then I think it needs to be, the costs need to be baked in to have a service catalog to say, well, to access these linked data sets has a cost, and that helps to fund the core facility. Would be a few thoughts.
Yeah, great question. Not much to add to what my colleagues have said, but I'm just sort of reflecting on the journey with UK Biobank. MRC was there at the outset, at the beginning, millennium, with the funding with Wellcome Trust. I don't think at that point any of the funders, either of the funders, main funders, would have seen how much we would have to invest or how far UK Biobank would go in terms of its kind of open science remit. And on reflection, and what we're now acutely aware of, as that particular investment grows and grows almost exponentially, so it increases every time we just put in more core support. It's sort of an increase in 30 or 40 or 50% on what happened in the previous 5 years. We recognise we can't afford to fulfil all those ambitions. And so we have to be a kind of, Andrew used the term yesterday quite a lot, convener, and also a pump primer, I think, of getting these initiatives off the ground. But then, as Andrew said, and I don't really like the term business model applied to science, but we do have to come up with a kind of business model that enables sustainability for these things. And that's the journey we're actually on, and we're living at the moment with UK Biobank, and challenging that organisation now to go out and find a sustainable funding partnership. Now, it will be a partnership. We'll continue to provide core funding, MRC, Wellcome Trust and others, but we can't match the ambition or the success Biobank has had. We can't keep up with it in terms of funding and the opportunity costs of not funding other things going forward. So I hope that helps.
Yeah, thank you. So I think that gives us a perspective of the longevity of these things, that they need to happen. And as Andrew has shown us, anything can change tomorrow or in the next, not just tomorrow. And we can't, try as we might, we can't future-proof what can happen. So, okay, I still have 4 minutes. So maybe I should ask another question, but so every one of you spoke about having it as open, but trustworthiness was a word that was brought out a lot during it. How do we actually make it open and yet feel safe to everybody along the pipeline, right? For the people who puts in the data, for the patients who we get the data from, and all through the people who sort of get funding to support it, and all through to the users and to the output. How do we get that trustworthiness to be cultivated in everybody who uses it? And I think obviously there is also a portion of return back to the people or at least let them know that we are doing good things with what they have contributed. So I think this is also relevant to biospecimens and data use. It's all relevant to the research that we use now, not just common resources that is, we can request and link, or even your own resources that you're going to generate as part of the research. So how do we make people trust us? We got a name called trust for our platform. I'm sure that's, there must be a story behind it that, it's come out at that level, but, how can we then make the community and everybody trust that we are doing good work with everything that we have? And obviously in the past we just share Excel files all around. So why, how does that, evolve to having a secure environment? Is it because we're just bringing too much data together? Is it because the data is getting too granular such that, we may be able to guess who that contributor is, and that's not safe? So how do we sort of build that trust, and how do we get there?
So I'm supposed to start first? I can. I think this is I feel that at the end of the day, and in the conversations we've had with Per, with Joe, and Andrew, it's really a endeavor about the various stakeholders and people that's involved, all the way from the contributors and the users themselves of the data. In fact, just from the trust experience, you would think that we spent more time on the technical part, but actually no. The time that we spent was actually talking to the stakeholders, to different custodians, to understand what their concerns are, and what it means and what they are worried about when they put their data on trust. And then working out in a very systematic and thoughtful manner how different parties are then responsible in different parts of this journey. I think the other part I want to highlight is that from a public perspective, I think this is one thing we spoke about a lot yesterday with Andrew as well. I think that's a very important component. I didn't talk about it here, but one big piece of work that we have in Trust is to develop many of these use cases, and we know that we have to do that together with all of you and the research community to generate the value and the use and demonstrate the use of all this such that we can bring this out to the lay people, to the public, to help them understand what is the value of doing all this. It is not just the risks that they may see in terms of exposing their data sets, but more in terms of the benefit to the society and also to the individuals, right, who has contributed data, and what does that mean to them. I think that's an important component that we will need to focus on to make this a long-term sustainable endeavor. Thanks.
So that's a really important question. And as an example, we have a problem right now, or of the last couple of years. So there's one journalist, a very well-known journalist in Sweden. She's opposing these kind of studies. She doesn't like us to have the agnostic approach that we just collect information and then in the future, well, conduct studies. The remarkable thing is that she is a nurse, and she's super smart. I met her a couple of times, but every time I meet her, she writes up an article in the major daily newspaper. And it has such an impact. It influences our recruitment. It goes down when she writes things like this. So our approach has been to be more transparent to our cohort members. So we have constant, sending out newsletters via mail and updating on what we do and what they contribute to, and it seems like they are happy with that. Out of the 70,000 plus women, 32 has withdrawn their consent, so it's not a major problem, but it has been a challenge, and we were not prepared for this. We were not prepared for the more or less attack, and because what she wrote was more or less close it down. This is not real science, and this brings out another problem. I'll stop there. Okay, please.
So a few thoughts. So I think definitions are important, and we have a tendency to talk about trustworthiness, and trustworthiness is being honest, reliable, and competent. So that's the first thing, being clear on the definition. Secondly, people talk about building trust, but I don't build trust with Per. I need to earn his trust. Trust is given. So, and I think that's a subtle difference. So, thirdly, we have at times a trust in data deficit as PERS, and it's ubiquitous. I think the distribution of trustworthiness in society is not Gaussian, it's bimodal. You've got people, often people who've lived with disease, have been in clinical trials, have benefited from new therapies, really enthusiastic. Here's my data. The majority of the population doesn't really bother and thinks it's happening anyway. Then you've got a small minority, but very, very vocal people who are very media savvy, who make a lot of noise. You know, someone called for my resignation last week on social media, you know. And it's you know, because there's a hard fought group there. So I think the way to address this is transparency. Secondly, weave public engagement and charitable sector engagement through everything you do. Because if I stand up and say, this is great, it's not as powerful as if patients stand up or Cancer Research UK stands up. And lastly, be really clear and articulate who's doing what with data for what purpose and what is the benefit share, whether that is in terms of new knowledge, new wisdom, or the benefit share, you know, if there is a financial component, and being really transparent about that. So this is why the governance of this is more challenging than the technology.
Could I ask, so do you think also, I mean, normally researchers, we hide a little bit, we're not the media savvy types, but should we change that? Should we be more offensive and go out and say that we're not doing this to earn money primarily or to collect information to make you feel bad or look bad, but we do this for some kind of greater good? Should we be more offensive than we have been before?
So I think, well, offensive, it's about definitions. Because offensive has various. So I think we've sort of been here before. For example, 20 years ago, genetically modified crops was a big thing in the UK. Experimentation on animals and the scientific community tended to hide away. What I think we've seen, which was accelerated during the pandemic, is a better engagement with the media. And I think we should consider how we engage with media. In the UK, there's a great organization called the Science Media Centre, and they act as the interface between science and all the mainstream media outlets. And they hold seminars where maybe 20, 30, 40 journalists will come. And our role as scientists is not to be celebrities, but to explain the science in terms that can be harnessed. So I think engagement systematically with the media. Is there a Science Media Center equivalent in Singapore? Yeah. So there's a lady called Fiona Fox. She's wonderful. And she's actually educated the scientists how to be more offensive. No. Participative, if I...
Very little to add, but I think one of the things we learned, we saw it a little bit through the pandemic, and Andrew used the term in his presentation about this idea of publics, and we can very easily think that the public are just one amorphous kind of, you know, group. You communicate with the public, you have one public-facing message, and so on. And I think we have to be much more sophisticated than that. Just as we practice stratified or precision medicine, we have to think about precision communication and think about how we stratify our messages and how we get the most influence when we talk to particular communities. Because otherwise, we will leave people behind, and there will be doubters, and there will be people who are just too easily preyed upon by people who want to dilute the message or are antagonistic to what we're trying to do. So I think we have to have a sophisticated communication plan.
Right. Thank you. I took a bit more time than anticipated. I saw 3 questions. Maybe we should start from there. The gentleman in the check shirt, can you go towards the mic so that we can actually record and hear you?
Thanks very much for a great session. My name is David Hipgrave. I'm a newly appointed Professor of Global Health here. Questions mostly for Andrew, I think. The first one, you started off by saying we're on the cusp of a new era of physical, computational, and data science, but the examples you gave of the research that's emanated from the big data so far were very linear. COVID does this, vaccine trials do that, etc. My first question is, how are we clever enough as a race to come up with the questions that can deal with the complexity that could be part of that big data, the context of the data, the content, and can we design research that can answer the complex questions, some of which have been alluded to, like the environment and the influence on health, or our genetic makeup, etc. That's the first question. The second question is about the abuse of data by big pharma or by even by academics who want to get published first. Thanks.
So don't leave the mic, because I'm going to ask you what you think. So it's a good question. I would argue we're beginning to see the application of new statistical and computational approaches to the analysis of large data. Indeed, in the news today, there was the example of, I think it's actinomyces, it's a resistant bacteria, and how they've combined laboratory science with artificial intelligence and then gone back to the laboratory. So it's almost bi-directional translation to identify 6 candidate repurposed antibiotics, which would, with a little bit of tweaking, be... So I think we will start to see, and that's why I apologize that my talk was linear. But that's why I think in an audience like this, we would benefit if we did have statisticians, mathematicians, and computational scientists who look at the world differently. And I think those institutes or institutions that get that blend right will really exploit this. I'd be really interested to hear what you think, and congratulations on your new appointment here. So, secondly, very briefly, I think the academic incentives conspire against team science, because often you work as a team, and then when you go up for your annual appraisal, they say, "Oh, this is great, but what did you do?" And the 3 metrics are impact. Are you in nature? Sustainability. Have you got a big grant? And thirdly, esteem. Have you been invited to the Karolinska to give a talk? And I do think we need to look at the funders to credit and accelerate the career pathways and reward for folk who are assembling these world-leading infrastructures. Look at CERN in Switzerland. So what we're trying to do is create the CERN for biomedical research, and you need to reward the physicists equivalents who are doing this. And the incentives, especially in medicine, are misaligned. But what do you think?
On the big data issue, I think you're right. It probably needs people who think very broadly about questions and how we might approach. But I think it will need better people to come up with this.
Thank you. I see Wenpui has her hands up. Can you make your way to the mic? Thank you. And then Suchi.
Hi, thank you very much. I'm Wen Pui, the PR of the Singapore Chinese Health Study. So today we talk about the set of cohort studies for observations. This is, remember what Professor Adami from Karolinska Institute and his colleague has published in 2008 in Epidemiology with a proposal that a new strategy might be to nest randomized interventional studies in large cohort studies and biobanks to study the effects of lifestyle on health. That was about 2008. 10 years have come and gone, and in the past 10 years, there was buzz, there was interest. I even felt the pressure to nest an intervention study in my own cohort. But today, I actually don't know any cohort that has done it, not the Nurses' Health Study. I don't know whether the UK Biobank has nested intervention studies. So I just want to hear its expert opinion, whether we should still be thinking about the potential of nesting intervention studies into cohort studies to add value, or is the jury still out there, or should we just continue doing observation studies in cohort and let intervention studies be established especially for that purpose?
Thank you very much. And I remember the paper that Hans-Olof wrote, and it made a big impact, I must say. So I think that we must go beyond observational studies. So I mean, the evolution of epidemiology has been tremendous over the years. In 20, 30 years ago, we looked into associations between X and Y and found out there was an association or not. And then now, and we moved on to today, even my colleagues, the younger ones at Karolinska, they don't want to call themselves epidemiologists anymore. They want to call themselves prostate cancer researchers or breast cancer researchers because they do so many other things. I mean, 20 years, 15 years ago, we went into genotyping and we had a presentation on PRS and influence, and it's such a quick evolving field, and why we should just do observational studies, I think that's behind us. We have to take the next step, and what we do slightly, we don't really use our cohort to identify women, even though what I told you about the low-dose tamoxifen trial and the other trials that we do is more or less identifying a problem through the cohort approach, and then take these results and these ideas into an intervention study, where most of our women in the low-dose tamoxifen trial actually are members of the cohorts, you could say, and we have communication with them. So that's also the beauty of a cohort. Today it's easy, social media, we have something we call the Karma app, so all these 70,000 women have an app, so we could communicate with them. So it works out quite nicely. We're not really there yet, but no.
Okay. So we should just remain true to our calling, our intent, right? Is that so we should observational cohort studies should remain true to their intent of making observations.
Absolutely. I mean, I didn't say that we shouldn't conduct observational cohort studies. That's essential. We should continue with it.
Yeah,
cohort
but not
studies
to nest it in the cohorts. Is that right? You wouldn't recommend that. I mean, the cohort participants can be free to participate in these trials, but not to intentionally nest it in the cohort.
Cohort studies could be used to identify problems, and if you nest your intervention study into a cohort, yes, that's one way forward. I don't think that necessarily has to be the case. Yeah.
Thank you.
So just very quickly, I obviously didn't explain it very well, but Biobank and Our Future Health, which I mentioned, Biobank doesn't do interventions. Interventional studies is part of it. It's a traditional kind of epidemiology, but I think with Our Future Health, the ambition is to intervene. It's a bigger study, and that allows opportunity to do that. But I think you have to move on. And particularly as a funder, we're asked all the time, surely there's not more description of problems. How are we going to address the problems? So I think, although description is really important, and understanding and getting precision around those descriptions is really important. Doing good observational studies has always been room for that. But I think you also have to think about how do we take things forward.
Thank you. Suchi?
I'm very nervous because I'm between you and lunch, so I have to be very brief. I'm an endocrinologist by training, so I'd like to ask perhaps Professor McNamara that what would be the funders' consideration when you are sort of having applications. One is population non-disease specific cohort versus one which is a disease-specific cohort. So these are sort of different type of cohorts. One is not committed to any particular disease, whereas one is deep into one disease. So what would be the consideration of the funders in terms of trying to evaluate these two type of proposal, so that we can, if we go in one of this type of application, we know how to sort of bring out the values of that kind of cohort, I guess.
Yes. Yeah. Well, as I tried to indicate, it's complicated, and some of you will have participated in funding panels, so you will have some idea of what it's like when you get different types of applications come before you, if you've got a broad remit within that panel. And I think it's really important for the funders, as a funder, we're able to maybe take a bit of a step back and think strategically, or try and think strategically about the balance of our funding across lots of different areas. And while we always want to follow the best research and the best ideas and to not hinder those and enable them to be taken forward quickly, as science demands, we also have to think strategically about the future and enabling things for the future as well. So we're constantly trying to maintain that balance. And it's not easy. As I say, I tried to in my talk hint at that, but it involves quite a lot of work kind of behind the scenes to get strategic thinking into the decision-making processes. Difficult when funding is tight, I have to say.
Thank you.
All right, thank you, Suchi. Okay, one last opportunity for burning questions. If not, you cannot sleep tonight. Jing Yu?
I'm Chen Jinyu, a cancer scientist and also an epidemiologist here from NUS. So my questions are for Andrews. Just now, we didn't see many biostatisticians or computing scientists here in this room. And you're expecting that after 10 years, I can see more, but actually, you won't see many. The reason is that although we keep training statisticians and computer scientists, but the challenge is that the majority of them they won't stay in the academic institutes. Right? I saw you also train a lot of data scientists in the UK. So my question for you is that how do you retain them in the academic institutes? Basically, many PI here, we have many vacancies for data scientists, but we cannot get anyone. So are you able to send some, any of them to Singapore?
Yeah, well, British Airways fly daily, so we'll just send them over. No, it's a challenge we have because. But I do think it oscillates. The same day that Microsoft laid off 10,000 people, they put $10 billion into OpenAI. So I do think this is cyclical. Currently, there is a drought in the UK, however, because industry snaps these people up, and we can't compete. So there's two approaches. What we're currently for, an MRC, to be credited for this, are looking for academic industrial fellowship programs where we have greater porosity between academia and industry at the fellowship level. The second thing we've noticed is, some people make ridiculous amounts of money in industry. And we've got people on our staff, a couple who've come out of industry, retired in their 40s. Can you imagine that? That'd be great, wouldn't it? But then thought, oh, well, actually, I don't want to go into the fintech sector. I want to do something that's in the public interest. So we actually try to target folk at a senior level of industry who are willing to come in at a lower salary comparatively. But it's really hard. It is really hard. Good question.
You can throw the question to YY as the Dean of School of Public Health. How can you generate more people, MPH, PhD otherwise, who can actually use R, Python, and cloud computing as the skill sets that we will now push out into Singapore? Okay.
Regrettably, the dean lost his own data scientist to the industry. When the industry offered my research fellow double the salary.
Yeah.
Yeah. So I think this is a universal problem that we all are facing, whether UK, Sweden.
Absolutely the same.
Yeah. So maybe we just have to wait for another breed of people who are interested in numbers to come up. All right. We are about 10 minutes beyond the time. Thank you for coming, and let's thank our speakers for the talk today. And there is lunch at the level 2 foyer, so please, continue to interact with.
Well done, sure.
Well done.